Hi, I'm Will Potter, and I'm here with Mike Smith of the College of Pharmacy at the University of Michigan. Mike, before we get started today, can you tell us a little bit about your work and your background and what you're doing here at U of M?
Sure, thanks for having me. So, I am a clinical assistant professor at the College of Pharmacy and a clinical pharmacy specialist in pain and palliative care at Michigan Medicine. And that basically means that I take care of patients at the hospital and clinics that either have a terminal or life limiting illness or have chronic pain. And so I see those patients on the inpatient side as well as the outpatient side.
So you're seeing and discussing every day firsthand opioids and how they're being used in both a clinical sense and, seeing how this is being described in pop culture and the press as well. So can you tell us a little bit about what this crisis is, how you would define it, and why it's significant right now?
Sure. I think it takes a little bit of history to think about why this really started and where we're at today. And so years ago, we determined that, or it was decided that pain was the fifth vital sign. And so this began kind of one end of the pendulum where we were treating pain very aggressively without knowing as much as we do today. And so there was overuse of certain medications because we thought they were effective. And what we've come to realize today is that a large number of these medications, particularly opioids, are not effective for many pain states. They're only effective for certain pain states. And so because we've had this issue where we've been over-prescribing or over-utilizing this class of medications, it has led to an abundance of pills in the community and has really potentiated addiction disorders.
So before we go any further, what is an opioid? I think that's something that's often left out of the discussion. I mean, maybe if you had back surgery, you know what certain prescriptions are, but what is this class of medication?
So the opioid is any drug or medication that works on what we call an opioid receptor. And so we have three subtypes of receptors, which are fairly important to know the differences when you're practicing. But for the lay public, essentially, you have receptors all over your body, these opioid receptors. And so these medications or even drugs, illicit drugs, hit these receptors and act on them to cause a response. And those responses can be different. And so we think of things such as heroin as an opioid that's an illicit opioid. It is the same essentially as morphine or oxycodone. They're all effectively working on the same receptors within the body. And so an opioid is anything that just works on these certain receptors within our body.
And so when we hear the term discussed as this opioid crisis or epidemic, is it talking about the entire spectrum of opioids, or is it some within that in particular?
It's really talking about all of them. And if you look back over the years of what has happened with this epidemic or this crisis, is it waxes and wanes. And so we know that there are risk factors and protective factors for substance use disorders. One of those risk factors is just the availability of a medication or a drug to be used. Is it accessible by the people that have other risk factors to abuse that drug? And so heroin used to be very cheap, and so heroin was abused, and then oxycodone or OxyContin came on board. And so the pattern actually switched from heroin abuse to oxycodone abuse. And then
because it was more available?
Because it was available, it was new, and then they made it abuse deterrent. And so then the epidemic switched back more towards heroin. And so they all have the potential to be abused. It's a matter of what is accessible. And so when we talk about the opioid epidemic in the news, you're hearing more things about OxyContin and heroin. But more recently, we've had a lot of cases of fentanyl overdoses as well, particularly in the state of Michigan. So it's really this entire class of drugs that can be misused that lead to these issues.
Thinking about how those drugs are prescribed, how does something like that differ from, any other over-the-counter painkiller or any other pain management you might prescribe to somebody? I mean, what is so significant about this that might have those either addictive properties or is kind of causing this crisis, so to speak?
The majority of other medications that we use to treat pain don't have euphoric properties and don't have addictive properties, and they work on different receptors than the opioids do. And so one of the side effects that we know about opioids is that they can cause euphoria. They can cause this feeling of high, particularly when they're being used inappropriately or they're being used at doses that are inappropriate. And so that effect is not just limited to opioids, but it's the class of medications in which that effect is the most pronounced.
And we were talking before we started filming today about kind of the differences in your academic work or here at U of M, how you're talking about this in the classroom versus how it's often talked about in the press or in, like you said, kind of lay person discussion about this. Could you explain that a little bit more and what you're seeing?
Sure. When we have health education learners, they're looking more towards how can they appropriately use medications. And so the news that they're hearing, they're not fully grasping what's being put out there because they're still trying to understand how they're going to fit into this role in society, what they're going to do to appropriately use these medications. Whereas when we see patients who are watching the news, their biggest concern is becoming addicted to these medications. And so there's a barrier between both learners who are then going to be practitioners and patients. Patients tend to be afraid and not want to use them, which can lead to bad outcomes as well. Their pain can be worse and things along that line. Whereas students haven't yet totally grasped whether or not what their role is going to be until they start seeing those patients that are asking those questions and bringing up the news articles that they've been reading.
And so if I'm a patient that is seeing all this in the news, like you said, and is concerned about this and apprehensive about even getting that prescription that I need, what is a possible conversation that might take place between the healthcare provider or the doctor and the patient? Do you try to explain to them how do you use these responsibly and why you think they're necessary, or do you hear that and try to find another solution?
There's a number of things that should be discussed, and any patient can go into any pharmacy and talk about that with their pharmacist, but it should also start with the prescriber who's giving that medication to them. And so the things that patients should look out for would be number of pills that they're getting. Mm-hmm. Is it going to match what type of pain that they have? As an example, after you get surgery, most pains from surgery are going to go away within 1 to 2 weeks. So your prescription should line up with that. You shouldn't be getting a prescription for 30 days or more if your pain is only going to last those 2 weeks or so. And so helping patients understand their pain is important. And then appropriate use in terms of how often you should be using it, what side effects you should look out for, and then how you should store it. So you should keep these things away from children, and correct disposal once you're done with that medication so that these medications are not left out there. And so that's one of the things that we're seeing is that because there's been overprescribing, there's abundance of pills in the community that don't need to be there anymore.
Well, and I think we all have anecdotal evidence of that, of having, injury and then, well, I didn't need all of these, but maybe I'll get hurt again or something else in the family will happen. So what you're saying, to be very clear, is that you shouldn't just hold on to those pills if you have, a half a bottle or however many left. They should be disposed of properly to help stem some of these problems.
Correct, because the next injury that you might have might not be the type of pain that's responsive to that opioid. And so that could lead to misuse of that drug. And so it would be better to get rid of it and then be reevaluated each time that you might have a pain or an injury.
And I think that point's really left out of a lot of the discussion. We think of drugs like this, of really powerful painkillers that are just universally applicable no matter what you're suffering from. And I wasn't aware of that if you hurt yourself in a different way or there's a different issue that comes up, it might not even work.
Correct. And a lot of the use that we started early on came from we know that they're effective in patients that have cancer pain. And so a lot of the use in patients without cancer that had different types of pain, we were using that data in cancer pain and saying, look, it's effective in these patients. It should be effective here. We didn't really have good studies in non-cancer pain and the long-term effects. And so we've been getting more and more of that data. And that data is telling us that the risks often outweigh the benefits of those medications.
Well, and speaking of studies like that, can you tell us a little bit more about the research you're doing here at University of Michigan and how that's relating to this crisis that we're seeing in opioid use?
Sure. So I have two big projects going on, and one of them I'm working with another provider, a physician, and we are looking at what can pharmacists do in primary care clinics to help manage chronic pain patients. And so what we're doing is we're seeing patients that are within one primary care clinic that have chronic pain, and how can we better treat their pain? Because physicians have 15, maybe 30 minutes with a patient. And in the types of medical histories that these patients have, that time is going to be eaten up very quickly. And so fortunately, I can spend a little bit more time with them and then assist the providers in coming up with better ways to manage their pain rather than just using an opioid. So one end of my work is in optimizing the use of pain medications in the primary care setting. And then the other end, because I work in palliative care, is trying to optimize the safe and effective use of these types of medications in patients, particularly with cancer pain.
And so is this a new development, thinking about those interactions in that way? I guess what I'm trying to get at is, has that been siloed off before that, the physician, the pharmacist, other players in patient care? I mean, is this crisis causing people to communicate more about this or try to come up with different solutions?
It's different by state based on state laws.
Okay.
And luckily in the state of Michigan, we have a number of pharmacists in ambulatory care and primary care clinics. And so there's been that interaction going on for a while. But there are places, more rural areas, that may not necessarily have access to a person with the expertise and training that they can talk to on a regular basis. Whereas when I'm in the clinics, I'm sitting right next to the physicians, and we're working together to better treat those patients. And so part of this epidemic has caused us to have more of these conversations, or to find more resources for both providers and patients to better take care of patients. And part of it has been going on, and it's just putting more people in the right spot.
And kind of continuing that thread, what are some other changes that could be made in how opioids are being prescribed, or this issue is being addressed, that might start to stem this issue and lead to some solutions?
I think there's a good amount of work being done here at the University of Michigan on post-surgical pain, and trying to figure out how many pills should you get or should you require post-surgery. And so I think the most effective step that we're going to have to working with this epidemic is preventing it up front. So minimizing the amount of medications or pills that are out there to be misused is step one. And so identifying how many pills patients should be using, and quickly identifying if they're showing substance abuse disorders, and then providing them with other things such as a naloxone prescription, which is the antidote essentially to an opioid. And so we've seen across the country here is that just providing those prescriptions, even if it's in the community, has lowered mortality rates or death rates. And so that's another avenue. So I think one of the most effective strategies is identifying upfront how can we minimize the amount of medications that are out there. The next step is then early identification and treatment of these substance abuse disorders so they don't get worse.
On that note about the antidote, so to speak, at what stage is that made available? Because, I mean, my first kind of thought as a journalist would be that people would be naturally reluctant to come forward and to say that they're part of this thing that's, has negatively portrayed in the press and has all these dangerous implications. I mean, how do you wrestle with that and make people both more comfortable to come forward and to make that more available?
I think it's talking about the risks and benefits up front with patients and being honest with them of what could happen. Mm-hmm. And so many states here have gone to a situation in which there's a standing prescription from the state by which any patient or family member can go into a pharmacy and request that naloxone. Oh, wow. And so that happens here in the state of Michigan. So the availability is getting there. And so I think it's a matter of being upfront with the patients and saying these medications have risks to them, and then thinking about what risk factors does that patient have that could put their risks even higher. So as an example, using other medications, using a certain amount of the opioid, these tend to add risks of respiratory depression and overdose to these patients. And so it's a matter of having frank discussions up front and then saying, if anything were to happen, this would be the way that we could reverse those situations. But you don't want to ever get to the point really where you're having to reverse or use an antidote. You want to prevent those things from happening up front. And in order to do that, having frank discussions that the patients understand and can take home to and can relate to is the most important thing.
So I'm hearing a lot of threads of solutions here, both with, reducing this overflow of excess drugs that are out there in communities, those frank conversations, communicating with physicians. What else, if you had your magic wand or wish list, both in your area of expertise or in policy, law, social services, what would you really like to see happen to help address this issue right now?
I think I would like to see more connections between community pharmacists, those that are based at a CVS or a Walgreens or wherever, and the providers and health systems, and then across state lines. And so there are some states that allow you to check what's called a prescription drug monitoring program. So you can see their fill history for controlled medications, which an opiate would be one of them. And so that's helpful to identify when and where they're filling it and how often they're filling it. Not all states have that available for everybody to look at. And imagine the situation in which you're the community pharmacist and somebody is coming to you with a prescription for a large amount of medication, and that's really the extent of the information that you have. How do you then decide whether or not that prescription is appropriate? What steps can you take? Do you want to call the prescriber on every prescription that you have when you're trying to fill 400 or so a day? Right. So I think giving people information by which they can then make better decisions is an important step. So ideally, I would like to see where all of us in the healthcare industry are connected to each other, can see the important pieces of information that are leading to that decision. Maybe that prescription is appropriate, and that could lead to harm if that prescription was stopped, if the patient had cancer pain, as an example. Maybe that prescription's inappropriate, but how is that pharmacist supposed to make that decision with very little information? And so I think that putting everybody in better situations, putting the providers in a better situation, having more of that patient's data available to them, having access to a pharmacist, putting pharmacists in better situations where they have access to the medical records or whatever it is they would need to make a better decision for that patient.
So when we're thinking about solutions like that, and someone like a community pharmacist, if they identify something that raises a red flag with them and they want to put in a call to the physician, how is that received by the physician? Is it seen as, someone trying to second guess their area of expertise? What you have here, multiple experts potentially butting heads about this, or, wondering if that amount of pills is correct. I mean, is that an issue in addressing this problem, or are people collaborative?
It can be at times, if you think about how busy providers might be. If that prescription came out of the hospital and that provider is then going into surgery and then they're getting called about a prescription they wrote 8 hours ago, but they have a long day ahead of them, it can be difficult. But I think at the end of the day, everybody realizes that each healthcare provider is trying to do what they think is best for the patient. And even if those discussions are uncomfortable and people might butt heads, if it leads to better care for the patient, that's the ultimate goal. And I think that's the most important thing.
That's very well said. Well, Mike Smith, thank you very much for joining us and talking about the opioid crisis, and thank you for joining us on the Teach Out.